Welcome to the deep dive. Today we're really getting into standardized photography and plastic surgery. It's fundamental, isn't it, for medical legal stuff, teaching, research, checking our results.
Absolutely. And, even for showing patients potential outcomes. But the key thing is, if it's not standardized, it can be pretty misleading.
Right. So consistency is paramount.
Exactly. It demands a routine, a systematic approach. Protocols, attention to detail, that's what we need.
Yeah.
And using a standard set of shots for each procedure.
Okay, let's break that down, starting with lenses.
Yeah.
Why is the choice so important here?
Well, it's mainly about avoiding distortion and keeping magnification consistent. The rule of thumb, especially thinking back to 35mm film days, was a focal length at least twice the diagonal of the image plane.
That helps keep things comparable even if different people take the photos.
Precisely. It standardizes the perspective.
So we have normal wide-angle telephoto. Can you quickly run through those, say, using the 35mm reference?
Sure. A normal lens, maybe around 50mm on a 35mm camera, mimics human vision, roughly.
Oh.
Wide angle, like a 20mm, obviously captures a much wider field.
And telephoto?
Telephoto, maybe 105mm, gives you a narrower field of view but magnifies things further away. Take portraits, focusing on details. And remember, digital sensors are often smaller.
Ah, the crop factor. So you need that multiplication factor to know the equivalent focal length.
Exactly.
Yeah.
To keep comparisons valid across different cameras.
Okay. What about other basics? Lighting, color.
Lighting needs to be consistent. A dedicated flash, ideally, or a fixed lighting setup. You can't compare photos taken in wildly different light.
In color management, that gray card thing.
Yeah, the 18% gray card is, for reference, helps you get accurate color balance. Yeah. And you absolutely need to white balance the camera correctly for the light source you're using.
Makes sense. And just practical prep. What needs to be done before you even take the shot?
Oh, simple but crucial things. Jewelry off, glasses off, heavy makeup needs to go. They just distract or hide things.
Keep the area tidy, use a background.
Definitely. A clean, plain background minimizes any visual clutter.
Right. Let's switch gears slightly to terminology. Stuff surgeons really need to grasp. Aperture first.
Okay, aperture. Think of it like the pupil of your eye, or the iris in the lens. It's the opening that lets light hit the sensor.
Measured in f-stops, right. F numbers.
Yes, and it's a bit counterintuitive. A larger F number, like f16, means a smaller opening. A smaller F number, like f2.8, is a wide opening.
And that links to depth of field.
Directly. Smaller aperture, so a larger F number, gives you a greater depth of field. More of the scene, from front to back, will be in focus.
Okay. And shutter speed.
That's simply how long the sensor is exposed to light, how long that iris stays open. Digital cameras use electronic shutters for this.
You mentioned depth of field again. Why is that so clinically relevant for us?
Well, we need the important anatomy to be sharp, don't we? Depth of field defines that zone of acceptable sharpness. It's affected by aperture, like we said, but also how close you are, the focal length you're using, and even the camera's sensor size.
Got it. And focal length itself, we talked lenses, but the basic definition.
It's the distance, usually in millimeters,
Yeah.
from the lens's optical center to the point where light converges on the sensor. It basically dictates your field of view.
Longer focal length, narrower view, more magnification.
Yep. And shorter focal length, wider view.
Okay, let's dive into the digital side more specifically for clinical work. Resolution, what are we actually talking about?
Pixels, essentially.
Yeah.
How many tiny dots make up the image? Usually pixels per inch, PPI, or just the total count, like megapixels. The sensor captures light on this grid of pixels.
And you calculate it width times height in pixels.
That's right. But you need to match the resolution to what you're using the photo for. Web or email needs much less than a high-quality print.
So more megapixels isn't always better.
Not necessarily. Higher resolution means massive files, takes up storage, slower to handle. It's a trade-off. You need enough detail, but not overkill.
And the sensor itself, what's its job?
It's the chip that actually captures the light. Millions of pixels converting photons into electrical signals, which then become the digital image. You mainly hear about CCD or CMOS sensors.
And we store these images on?
Memory cards, removable storage. Compact flash used to be big, now it's mostly secure digital SD, SDHC, SDXC cards.
Different speeds and capacities.
Yeah. And you need to check your camera takes the newer types like SDHC or SDXC. Faster cards are better, especially if you're shooting video or bursts of photos.
Okay, image compression. Why do we need it?
File size, mainly. Raw images can be huge. Compression makes them smaller, easier to store and send.
Are there different kinds? Lossy versus lossless?
Yes. Lossless keeps all the original data. TIFF or RAW files are often like this. Good for archiving the best quality. Lossy compression, like JPEG, throws away some data to get much smaller files.
JPEG is common for photos, though.
It is. It's a good balance. But be careful. Every time you resave a JPEG, it can degrade slightly. Best practice is to work on a copy, keep the original safe.
Right. So practical camera features for the clinic, what should people look for?
Well, maybe a compact digital camera, perhaps one with interchangeable lenses if you want flexibility. A bounce flash is really useful.
What about in the OR?
There, maybe a point and shoot or one of those compact interchangeable lens cameras is easier to handle, maybe even cover. Minimum 10 megapixels is probably sensible now. HD video is handy.
An adjustable screen. Lens for low light.
Yeah, an adjustable LCD helps with awkward angles. A lens that performs well in lower light is good too. And you need manual settings available, not just auto. Plus spare batteries, enough memory.
And software to organize them all later.
Definitely. Don't underestimate how many photos you can accumulate.
So when choosing a camera, what are the main types and things to check?
You've got DSLRs, the bigger ones, with interchangeable lenses, compact point and shoots, and those hybrid compact interchangeable lens cameras, CILCs.
Focus modes.
Autofocus is convenient, especially if it can target anatomical areas. But manual focus is essential for setting precise distances for comparative shots.
Sensor size matters for quality.
Generally, yes. Larger sensors tend to have larger pixels, which usually means better performance in low light, less noise.
And zoom. Optical versus digital.
Big difference. Optical zoom uses the lens elements. That's the one you want. Better quality. Digital zoom just crops and enlarges the image. Often looks blurry. Aim for at least 3x optical zoom for face and body work. Maybe a 105 millimeter equivalent.
Viewfinders. LCD screens.
DSLRs often have through-the-lens optical viewfinders. Very accurate. Compacts might have simpler optical ones with parallax error, or just use the LCD screen. LCDs show exactly what the sensor sees, but use battery. Electronic viewfinders try to mimic DSLRs on smaller cameras.
Video specs.
Check the resolution, frame rate, if you can plug in an external microphone, recording time limits, compression quality, all important if you plan to shoot video.
And resolution overall versus effective.
Sometimes manufacturers quote slightly different numbers. Just be aware and compare like with like.
Let's circle back to focal length again, specifically for digital.
Right, because of those smaller sensors, the actual focal length number on the lens isn't the full story. You need the 35 millimeter equivalent or the crop factor.
So a lens marked 1855 millimeters on a crop sensor camera might actually behave like, say, a 2782 millimeter lens in 35 millimeter terms.
Exactly. You have to check the specs. Point and shoots often just give a zoom factor, like 10x zoom, which corresponds to a certain equivalent range. Again, check the details.
Okay, flashes. Built-in versus external.
Built-in flashes are harsh, usually direct, not ideal. A hot shoe on top lets you attach a much better external flash. Some cameras have a sync port for studio-style lighting, too.
And for clinical shots, you recommend?
A separate bounce flash is best, one you can angle maybe 45 degrees up, bounce the light off the ceiling, add a diffuser, gives you soft, even light. Much more flattering and consistent.
And for consistent comparison shots over time, fixed focal length lenses.
Ideally, yes. Using a DSLR or CILC with a prime lens, say 50 millimeter or 100 millimeter equivalent, you set the distance on the lens, then move the camera to get focus. That keeps the perspective the same.
But in the OR, maybe flexibility is more key.
Yeah, a point and shoot or a CILC with a tilting screen might be more practical. Strict comparison isn't always the primary goal intraoperatively.
Okay, let's talk magnification. How do we standardize that?
There have been attempts, like the Westminster and Cardiff scales of reproduction. They try to provide standard views based on body size. The focal lengths often suggested assume a full-frame 35 millimeter sensor.
So again, the smaller sensors complicate things.
They do. You need that focal length multiplier, the crop factor. Okay. Divide the 35 millimeter diagonal by the sensor diagonal. That tells you how much longer the lens effectively becomes.
And why does that matter for comparison?
Because if you take before shots with one focal length and after shots with a different effective focal length, even at the same supposed reproduction ratio, you can get distortions, like barrel distortion comparing a 15 millimeter view to a 105 millimeter view. They just won't match properly.
Crucial point. Now, infection control. Always vital. How do we handle cameras in the clinic and OR?
In the clinic, equipment needs barrier control, cleaning protocols. Treat it like any potentially contaminated surface.
And in the OR?
Strict sterility. Ideally, the photographer isn't scrubbed. Trained, non-sterile staff can often take the pictures. If you absolutely must photograph within the sterile field.
Special gear.
Yeah, things like sterilized underwater camera cases can be used. But segregation is usually the better approach.
Okay, positioning. Head positioning for facial photos seems like it needs real precision. Reference planes.
Absolutely key for consistency. The Frankfurt plane tragus to infraorbital rim is traditional, but can sometimes make people tilt back slightly, exaggerating the submental area.
So what's preferred?
Often, the natural horizontal facial line, patient looking straight ahead, like at their own eyes in a mirror, especially good for rhinoplasty. Keep the head vertically straight, top of head to top of photo, unless you're doing arms or hands, maybe?
And shoot wider shots too.
Yes. Context is important. Get the overview, then the close-ups. For oblique views, define your landmarks, tip of nose to far cheek, or maybe dorsum to medial canthus for rhino. Be consistent.
How do you ensure a true lateral?
Look across the oral commissures. They should line up perfectly.
Okay, let's run through some standard series. Face and neck lift.
Right. Vertical shot, hairline down to the sternal notch, camel level, centered on the nose usually, relaxed face, hair back, no distractions. Oblique view. Align the radix with the opposite medial canthus.
Any extra V's for that?
You might want one with teeth gritting to show platysmal bands. And a reading view, looking slightly down, can highlight submental fat better.
Upper brow and eyes.
That's usually horizontal.
Yeah.
Close-up, from just below the lower lid crease up to above the hairline. Keep the inner pupillary line horizontal. Get a relaxed brow looking up, and then eyes looking down to show any lower lid fat pads.
Laser or chemical peels.
Again, clean face. Vertical oblique close-ups of the cheeks are standard jawline to above the brow. Also, slightly wider lateral shots can show tonal changes down to the neck.
Hi.
And add a chest view if you're peeling the chest. Remove lipstick. Oblique view. The lowest part of the filtral column should line up with the opposite cheek. Lips slightly parted, relaxed.
Rhinoplasty and facial fractures, these need real precision.
Yes. Horizontal close-ups here. Camera parallel to the nasal dorsum. Need a horizontal line through the lower lateral eyes that's perpendicular to the dorsum. Full basal view. Tip between the eyebrows. Maybe adjust slightly if the tip projection is very low or the lip is large. Half basal. Tip just below the eyes. Relaxed face, hair back. Works for fractures, flaps too.
Supplemental rhino views.
Smiley shots, anterior and lateral, are useful if you've done a depressor septum release. And a cephalic view, looking down from the top, can show deviations clearly.
Okay, onto the body. General body series.
Vertical shot, weight even. Camera level with the mid-abdomen. Feet hip-width apart. Knees straight. Feet parallel. Arms. You can do arms out horizontally, elbows bent 90 degrees, hands forward. Or folded across the breasts, but not higher. Relaxed abdomen, generic underwear, no watch or jewelry.
Any extras for body contouring?
The diver's view could be good. Patient bends forward, relaxes the abdomen, shows skin laxity well.
Standard breast series.
Horizontal usually, shoulders down to below the navel, camera level with the areolae. Shoulders relaxed, arms back for reductions, lifts, reconstructions usually. Specific views needed for lat flaps sometimes. No jewelry.
What about tram flap reconstructions or male body shots?
Those are typically vertical. Shoulders to below navel again, camera parallel, centered maybe on the rib cage, relaxed shoulders, arms behind the body except for straight anterior posterior views. Generic underwear, no jewelry.
Now shooting in the OR, different challenges. How do you keep photos clean and sort of generic?
Yeah, it's tricky. Keep the field clean, wipe away blood, remove instruments, cover things you don't need in the shot with sterile drapes. Remove any patient makeup if possible.
And generic.
Means avoiding anything too specific or distracting. Generic drapes or undergarments. Cover identifiable tattoos if you can. Use a plain background if possible, not the clutter of the OR. If your hand is in the shot for scale, make sure it's gloved, and watch out for brand names on equipment.
Good points. What about 3D imaging? It's becoming more common.
Right. 3D scanning captures a digital model, a point cloud, usually with color data too. Some systems can even capture movement.
And the clinical uses?
Capturing that 3D data, obviously. Simulating outcomes, which is powerful for planning and patient communication. Storing pre- and post-op 3D images for comparison, and actually measuring volumetric changes.
Okay, finally, and this is critical consent and IPO.
Absolutely non-negotiable. You need proper informed consent for any use beyond direct patient treatment. That means publication, teaching, any kind of publicity. Patient privacy is paramount.
So, IPay rules. Treatment photos are okay without specific authorization.
Generally, yes, for treatment purposes within the care team. But for non-treatment, uses education, talks, papers, website photos, media, you must have explicit written authorization.
Unless all identifying information is removed.
Correct. if you can remove all 19 defined hyphae identifiers. But that's often impossible for facial photos. Blocking the eyes is not enough.
So full face photos always need consent for non-treatment use.
Always.
Yeah.
And honestly, best practice is to get consent for any facial part used outside direct care, even if you think it's de-identified,
Yeah.
and always double-check with the patient before using photos, even if you have consent on file.
Cover jewelry, tattoos too.
Yes, remove or cover anything else potentially identifying. And protect the data itself. Encryption, passwords on computers, drives, everything. Don't view patient photos in public places. Use screen guards.
What about commercial use, metadata?
Metadata embedded in image files can contain hidden patient info. It must be scrubbed from any images used commercially or shared widely. Get written assurance from publishers that they'll do this.
This has been incredibly detailed. The big takeaway seems to be consistency, standardization.
Absolutely.
Hmm.
Uniformity is everything for accurate documentation in our field. Sloppy photos misrepresent results. You need to understand the basics, whether it's digital or older methods.
And choose the right tools for the job, thinking about 3D options too.
Right. Match the tech to your goals, but underlying it all.
Legal and ethical considerations first.
Always. Before you even pick up the camera.
Thank you. That was a really comprehensive deep dive.